I'm Maria Williams with the Collaborative on Health and the Environment. She enjoys bringing you the latest environmental health science through our partnership calls and webinars, science serves, publications, and social media. I would like to welcome everyone to today's CHAPE Partnership webinar, which is titled Environmental Contributors to Cardiovascular Disease, Emerging Research on Heavy Metals and Air Pollution. Our moderator today is Ted Shetler, CHAPE Science Director and also Science Director of the Science and Environmental Health Network. We will leave time following the presentations for a brief Q&A session. You may type in questions through the Q&A feature available on the menu bar at the top of your window at any point during the presentations. After the presentations, our moderator will read out questions for our panelists to respond to. We will get to as many comments and questions as we can during the Q&A period. For those of you who called in on the phone, we have posted slides to accompany today's webinar on our website. You can download these by going to healthandenvironment.org. Please scroll to the bottom of the page and select today's webinar. On the webinar page is a link to the slides. Everyone on the webinar right now is muted with the exception of our moderator and our speakers. This webinar is scheduled to last for 60 minutes and is being recorded for our call and webinar archive. With that, I'll turn things over to you, Ted.
Welcome to everyone who has joined us. Today we have three very accomplished speakers who we're very grateful have taken time out from their busy schedules to join us today and present some of their work. I'm going to briefly introduce each of them here at the outset, but I would encourage all of you to go to the call website to look at more extensive bio sketches there. The first speaker will be Dr. Bruce Lanphear, a clinician scientist at the BC Children's Research Institute and a professor in the Faculty of Health Sciences at Simon Fraser University in Vancouver, British Columbia. From 1997 to 2008, he was the Sloan Professor of Children's Environmental Health at Cincinnati Children's Hospital Medicine Center. Among Bruce's many projects and research activities, he's leading an effort to produce videos to enhance public understanding of how our health is inextricably linked with the environment and elevate efforts to prevent disease. Bruce will be followed by Dr. Anna Navas-Acien, a professor of environmental health sciences at Columbia University, Mailman School of Public Health. Her research investigates the long-term health effects of widespread environmental exposures, interactions with genetic and epigenetic variants, and effective interventions for reducing involuntary exposures. For more than 10 years, she has been working in population-based cohort studies, such as the Strong Heart Study, a study of cardiovascular disease and its risk factors in American Indian communities, and the multi-ethnic study of atherosclerosis. And our third speaker will be Dr. Aruni Bhatnagar, Professor of Medicine at the University of Louisville. Dr. Bhatnagar has spent more than 25 years studying the impact of toxic substances, tobacco smoke constituents, and environmental pollutants on heart disease. He is known for his pioneering work on the metabolism of toxic substances in air and tobacco smoke and how they affect the development of cardiovascular disease and diabetes. For the last 7 years, he has served as deputy editor of the American Heart Association journal, Circulation Research. And he currently serves as director of the Diabetes and Obesity Center and most recently named the new director of the Envirom Institute, both at the University of Louisville. So we'll start with Bruce and we'll go right through the presentations. And then, as Maria said, we'll have time for some questions and answers at the end. So with that, Bruce, please go ahead.
All right, thank you, Ted and Maria. As you heard from my introduction, I focus mostly on children's health and toxic chemicals. So I'm a little bit of a latecomer, certainly compared to Aruni and Anna. But I was quite struck by how lead as a risk factor for heart disease was overlooked. And so recognizing that from Anna's work and Ellen Silbergeld's work and many others, that we were underestimating the burden of disease, both nationally and globally, I decided to attempt to estimate the contribution of lead to the number of deaths particularly including even blood lead levels below 5 microgram per deciliter. So a brief introduction, which many of you may be very familiar with. Cardiovascular disease accounts for about 800,000 deaths, or about 1 in 3 in the United States every year. Deaths from coronary heart disease have declined quite dramatically in the United States, but still is the leading cause of death domestically and globally. And lead has already been recognized as a causal risk factor for both hypertension and coronary heart disease. 5 of the 6 prospective studies that have been done already found and reported a significant association of lead and cardiovascular disease mortality. The only one that didn't only involved 19 deaths from cardiovascular disease and was quite small. So the evidence is quite consistent. Laboratory studies have shown that lead enhances the development of atherosclerosis by inactivating nitric oxide, inhibiting endothelial repair, impairing angiogenesis, and promoting thrombosis. So it has all the mechanisms underlying atherosclerosis have been identified along with laboratory studies of lead. And yet no studies have calculated the number of cardiovascular disease deaths in the United States attributable to lead using a national cohort. And it's unknown if blood levels below 5 microgram per deciliter, which are typical for US adults, are associated with cardiovascular disease mortality. So we use the NHANES data collected between 1988 and 1994, and the participants were followed through December 31st, 2011. The National Center for Health Statistics staff linked the subjects with the underlying cause of death in the National Death Index. Using the underlying cause of death ICD codes in ICD-9 and ICD-10. They did previously do a validation study of an earlier NHANES mortality follow-up and showed that about 96% of deceased participants and over 99% of living participants were correctly classified using this algorithm. Just a few of the key measures, laboratory methods for blood lead. These were measured in blood during the medical exam of the NHANES survey. Lead was quantified in whole blood samples using graphite furnace, and the detection limit was 1 microgram per deciliter. About 9% of participants had blood lead levels less than the level of detection at the time, which was 1 microgram per deciliter. For those below that value, we imputed a level of 0.7 microgram per deciliter. We calculated continuous hazard ratios for an increase in blood lead for the 10th to the 90th percentile, which represents 1 microgram to 6.7 microgram per deciliter, and for the 10th to 80th, which represents 1 microgram per deciliter to 5 microgram per deciliter, using Cox proportional hazard models. And we calculated the population attributable fraction for continuous blood lead levels. Overall, over 14,000 adults were followed for a median of 19.5 years. 4,400 participants died, 38% from cardiovascular disease, and of those, 22% from ischemic heart disease or coronary heart disease. The geometric mean blood lead of the participants was 2.7 microgram per deciliter, and about 20% had a blood lead in excess of 5 microgram per deciliter. Not surprisingly, participants with higher blood lead levels were older, less educated, and more likely to be male. They were also more likely to smoke cigarettes, consume larger amounts of alcohol, have less healthy diets, higher serum cholesterol, and higher rates of hypertension and diabetes. As you can see here on these forest plots, after accounting for all those other factors, we saw that blood lead levels were associated with all-cause mortality, cardiovascular disease mortality, and ischemic heart disease mortality. And I'll show you the actual numbers in a moment, but first I wanted to show you the dose-response relationship, where you can see even at the lowest levels, it's, beginning at around 1 microgram per deciliter, already we see a fairly steep rise in the risk of death from cardiovascular disease, and well below 5 microgram per deciliter. And we saw the same pattern with coronary heart disease or ischemic heart disease mortality. again, a steep rise at the very lowest levels. So these represent a supralinear or a decelerating dose-response relationship and indicate that even at these low levels, even below 5 microgram per deciliter, there already is an increased risk. Now, going back and looking at the hazard ratios associated with the increase from the 10th to 90th percentile for all-cause mortality, the hazard ratio was 1.43, cardiovascular disease mortality 1.7, and ischemic heart disease mortality just over 2. You can also see here, represented in the paper, are all the variables that we adjusted for. During the review process, a number of reviewers suggested we should change from using categories to continuous measures for the covariates in some cases. In other cases, they suggested we shift from continuous to categorical. We did a number of secondary analyses to test how robust this was, these results were, and they changed relatively little. Next, to look at the hazard ratios below 5 in the population of subjects below 5 microgram per deciliter, consistent results with hazard ratios for all-cause mortality of about 1.4, cardiovascular disease mortality 1.95, and ischemic heart disease mortality 2.5. Next, we calculated the attributable fraction for all types of deaths. And as you can see here, for all-cause mortality, we estimated about 18% of all deaths, representing about 4,000 deaths. For cardiovascular disease mortality, 28%, representing 250,000 deaths. And ischemic heart disease mortality, almost 38%, representing 185 deaths from coronary heart disease or ischemic heart disease. Recognizing that these results, which are quite large, would be questioned, one of the things I thought might be real interesting is to go back and look at some of the trends in coronary heart disease deaths, because beginning about 50 years ago, there was a trend that was recognized in the mid-70s in the United States. By 1978, there was a 20% decline in deaths from coronary heart disease at its peak in 1968. And a conference was held, the Decline Conference, which they recognized this was a real decrease. It wasn't an artifact. And it was suggested at the time that perhaps coronary heart disease was preventable. And Jeffrey Rose pointed out that there was no change among the British men in the particular case, but still thought that perhaps it was preventable given the US data. Subsequently, the British men did catch up, and by the mid-1990s, you could begin to see a decline in coronary heart disease deaths after they removed gasoline. Of course, in the United States, it was reduced quite a bit further. It's not possible to disentangle air pollution and gasoline since air pollution really was leaded, and the majority of our exposure at the time airborne pollutants or leaded gasoline. Another striking finding during the 1980s, largely unexplained decline in hypertension from around 34% down to about 20% by NHANES 3 in 1990-94. This couldn't be explained by changes in the blood pressure cuff size, tobacco use, treatment for hypertension, age of the participants. But what did change, of course, during that time was that lead was taken out of gasoline, phased out considerably, and you can see a quite striking association here, or correlation, these are unadjusted, with the median blood lead levels from about 13 microgram per deciliter during NHANES 2 down to about 3 microgram per deciliter during NHANES 3. These superlinear or decelerating dose response relationships are not something that we typically think of or are familiar with in many cases, but they're increasingly been associated with PM2.5 and all-cause mortality in this particular case, or ischemic heart disease mortality as well. Benzene and leukemia, a similar exposure response relationship has been observed with the steepest increase in risk at those lowest levels of exposure. And while this evidence that even extraordinarily low level of pollutants or metals might be toxic is hard to really get our heads around, I wanted to show some data from that shows what happened following the ban on smoking in public places among non-smoking adults. They found a 20% reduction in acute heart attacks, which I don't know if anybody predicted something that large. So what we found was that lead exposure results in about 250,000 cardiovascular disease deaths and 185,000 deaths from coronary heart disease every year in the United States. And we found that blood lead concentrations less than 5 microgram per deciliter, which are typical for US adults, are associated with cardiovascular disease mortality. There's no apparent threshold. That's quite important because like virtually all the other non-carcinogens, we regulate lead as though there is a threshold or a safe level. And that means that we're failing to protect people, not only from lead, but from the other pollutants and toxins I mentioned, like PM2.5. The decline in lead exposure, which is entwined with air pollution and arguably many other metals, appears to be linked with the mysterious decline in coronary heart disease. And largely, at least among the medical community, along with air pollution and other metals, has been overlooked as a reason for that decline. Some of the limitations that are worth mentioning, the key ones, we relied on baseline measures 19 years before the death and the follow-up of these participants. And we relied on one blood lead test. We were unable to adjust for arsenic and PM2.5, which my colleagues will be talking about. On the other hand, we may underestimate the impact of lead exposure because we relied on a single blood lead test. Serial blood lead measures or bone lead has been shown to be a stronger risk factor for long-term outcomes associated with lead exposure. So in conclusion, low-level environmental lead exposure is a leading but largely ignored risk factor for cardiovascular disease mortality in the United States. Quantifying the contribution of lead is essential to understand trends in cardiovascular disease and develop comprehensive prevention strategies, especially perhaps in industrializing countries where cardiovascular disease and lead exposure is much more prominent than it is today in the United States. And finally, these studies collectively with others provide sufficient evidence to lower the allowable level of blood concentrations, blood lead concentrations for workers. Thank you.
Thank you very much, Bruce. And let's move now to Anna Navas-Acien and your presentation, please.
Thank you so much, and thank you, Bruce Lanphear, for this excellent presentation. And I am going to be discussing, continuing on the same topic, and especially focusing on arsenic, but also I want to keep touching a little bit on the issue of lead. And let's start with recognizing that the WHO has indicated that with the evidence available, that might not be updated, 31% of cardiovascular disease could be prevented globally if we could avoid exposure to air pollution, secondhand smoke, and chemicals. Currently, only the effects of lead on blood pressure are actually recognized by the WHO. But the new evidence is really emerging, indicating that metals can affect clinical outcomes more directly, not just through blood pressure. And a recent meta-analysis published by the British Medical Journal, combining 37 unique studies, and thousands of participants indicated that the evidence is very consistent with a clear dose response for arsenic, lead, and cadmium, with no consistency for mercury and some inconsistencies with copper. And I'm going to start talking about arsenic because it is widespread in water, in groundwater in the US across multiple regions of the country, affecting especially private well users, but also other community water systems, and also through the intake of rice and other food products. Arsenic is well known for its carcinogenic effects and also for its cardiovascular effects. And the evidence, the epidemiological evidence, goes especially through the case series and ecological studies quite early. Even in the 1930s, it was already recognized that German vintners and in Taiwan, individuals exposed to inorganic arsenic had black foot disease. And in Chile, there was an epidemic of cardiovascular disease affecting relatively early ages, and quite a trend in myocardial infarction following a very large epidemic of very high levels of inorganic arsenic exposure in the drinking water. That evidence was compelling, but affected mostly limited by ecological exposure assessment. In the early 2000s, with the findings published in 2011 and 2013, the HILS cohort in Bangladesh was one of the first studies to provide high quality evidence on the individual level assessment of arsenic exposure with clinical cardiovascular outcomes. This is part of the Columbia University Superfund Research Program that was directed by Joseph Graziano, and which I've had the honor recently of becoming the new director. And in this map, from a region of Aray Hazars, where this cohort, the HILS cohort is taking place, you can see that there is a lot of heterogeneity in arsenic levels in the wells. Each of these dots is a water well where each participants are drinking. And some individuals are exposed to low levels and the neighbor next there is exposed to high levels. And in that community, we could find a very clear increased risk of heart disease related to arsenic exposure. But what about in the US? Bangladesh is a poor country with many nutrition and many other issues going on. So we were interested in providing evidence for a low-level arsenic, more moderate-level arsenic exposure as found in the United States. And we partnered with the Strong Heart Study, which takes place in American Indian communities. And these communities are in Arizona, North and South Dakota, and Oklahoma, and are exposed to levels that are from below the current arsenic standard from the EPA, that is 10 micrograms per liter, to above, up to 50, maybe sometimes around 100 micrograms per liter. The exposure levels are shown in these spaghetti plots down there, were very constant over a 10-year period. And so participants who were exposed to high levels tended to continue to be exposed to high level over the years. And we were able to take advantage of the design of this study and measure the arsenic exposure in the urine samples of all the participants at the baseline in 1989-91, and to follow them over time and to understand if this higher exposure at the baseline could be related with a differential increased risk in the outcome, in the clinical outcomes. The study is put together, is done in a very interdisciplinary way, and also working very, very closely with the communities. And we have a fantastic team of cardiologists and clinicians who are actually reviewing all the medical records for the outcome assessment. So as shown in this table, we found that arsenic at the low moderate levels of the US, there was a dose response very clear for cardiovascular mortality and also for incidence, although a little bit less weaker. And if you look at the dose response curves using flexible spline models, we can again see that there is a clear increased risk above 10 micrograms per gram of creatinine to account for urine dilution issues. But at the low levels, the dose response is not so clear. And, but the confidence intervals that are marked by the dotted lines are very wide. So for arsenic, we have clear evidence above around 10 micrograms per gram of creatinine, that is equivalent to microgram per liter, but not so clear at the low level. These findings were consistently replicated in another study in Colorado, what is important, and also in an animal model that has tendency to develop atherosclerosis. A clear also dose response, although the low level was also non-significant. So we have a substantial number of mechanistic additional evidence based on the Stronghold study looking at increased risk of atherosclerosis, prolonged QT interval, diabetes, albuminuria, chronic kidney disease, all relevant potential mechanisms for this increased risk in cardiovascular disease. So together with the available evidence, we were interested in understanding better what is the dose-response relationship. So we pulled all the cohorts available worldwide, and we could find again a lot of consistency across all studies that are available, supporting that yes, arsenic is a risk factor for cardiovascular disease. However, trying to look at the dose-response relationship, it's not totally clear at the low level if it's linear, as suggested for the coronary heart disease mortality, or if it's maybe non-linear and there is a threshold, as potentially suggested for the coronary heart disease incidence. But in both cases, the non-linear model was lacking statistical power, especially because there are very few studies at low-level arsenic exposure. We are trying to address this limitation in the current evidence by looking at an additional population that is exposed to arsenic at relatively lower levels in the MESA multi-ethnic study of atherosclerosis, which is an urban city cohort in the United States. You can see that within that cohort, there is substantial variation in arsenic exposure levels by race and also geographically. And the question is this differential arsenic exposure contributing to increased cardiovascular disease risk? We don't know, but we just got a grant funded recently, and we'll hope to be able to answer this question in the next couple of years. I want to briefly talk about lead and cadmium again, as was discussed by Dr. Lanphear recently. And the evidence for lead as an atherosclerotic risk factor for cardiovascular disease is relatively old, and already the British Medical Journal in 1886 published a very interesting case report, autopsy report, showing the cardiovascular effects of lead. But somehow that evidence was lost. In 1968, lead production peaked in the United States. As interestingly, coincidentally, 1968, as was mentioned earlier, was also the year that cardiovascular disease also peaked in the United States. So we have, we are interested in that question, and we found also evidence that actually this decline in lead exposure could be contributing to the decline in cardiovascular disease, also using NHANES data, with very similar results as Dr. Lanphear showed. 22% of the deaths could be attributed to changes in lead, and 8% attributed to cadmium, consistent with Dr. Lanphear's study, which had a major impact in the media. So the question is, what can we do to prevent these effects? So I want to talk about chelation and an ongoing trial looking at cadmium lead chelation in the United States. A previous trial already found that chelation of metals could actually be related to cardiovascular disease prevention, an 18% reduction. However, and you can see here how the metal levels increase, chelation can effectively remove lead and cadmium dramatically in adults. Other things that we can do beyond chelation is actually preventing exposure. As I mentioned, arsenic is through drinking water. So we have right now a clinical trial looking at the impact of removing arsenic from the water. And we are going to be also looking at cardiovascular markers in the study, and this study is currently ongoing. I want to mention, to finish, the issue of metals in electronic cigarettes, as these products contain metallic coils that are heating the the aerosol, which is inhaled by the user. So we really need to know the potential role of these products in cardiovascular toxicity. And thank you very much, everybody, for the attention. Looking forward to the questions.
Thank you very much, Anna. Wonderful information presentation. And let me remind participants that if you have questions, don't hesitate to type them into the chat box, and we'll get to them at the end. Let's move now to Dr. Aruni Bhatnagar and your presentation, please.
You can see my screen, is that it?
Yes.
Okay, good afternoon. I'm Aruni Bhatnagar, and what I thought I'll talk about is air pollution and heart disease, which is sort of a larger subset of a problem, has to do with the exposures to adverse air pollution components and the cardiovascular disease risk that is associated with such exposures. So we know from many estimates now that in the United States, nearly about 150,000 to 100,000 people die prematurely from exposure to air pollution, with most of these deaths could be attributed to cardiovascular disease. But worldwide, it's been estimated that over 7 million people die prematurely because of exposure to particulate air pollution. If you look at the global burden of disease, then air pollution in association with things like tobacco smoking, secondhand smoke, and as well as indoor air pollution accounts for a very significant portion of the global burden of disease. Therefore, it's important to understand not only what are the causes of air pollution, what are the emitters, also what are the outcomes and what may be the underlying mechanisms by which air pollution affects disease. So if you look at air pollution first, it's a rather sort of complex mixture, a variety of different chemical and physical constituents. The most sort of popularly studied component of air pollutions are the ambient air particles. These particles come in many sizes. They can range from PM10, which is PM10. There's a particulate matter of 10 micrograms, which is of aerodynamic diameter of the particle. There are PM10, PM10 to 2.5, PM2.5, and then the ultrafine particles. Now, these particles, if they are coarse, are readily removed by the upper airways, but the fine and the ultrafine particles can actually penetrate deep into the lung and perhaps toxicologically the most significant in terms of disease and injury. So these particles are emitted from a variety of different sources. Some of them are well defined, but if they're very small, it's difficult to even find out what specific geometry they might have. But there are many sources of PM. They could be natural sources as well as anthropomorphic sources. There are forest fires and natural emissions from plants that can emit these particles, but the major variety of sources are derived from human activity and from anthropomorphic sources. Now, the composition or the sources from which PM arises in, say, an urban environment differ from one place to another. In Midtown Manhattan, for example, most of the PM comes from diesel sources, whereas in other cities, and there are some examples here, they could be coming from coal, from some mobile sources, from fuel oil, and there is this difference because of the different both mobile and stationary sources within a particular urban location. So if you look at the entire country, you can see that most of the air pollution is limited to few areas. Of course, there's the East Coast, but mostly the Ohio Valley where we live. It's a rather high concentrations of PM in that area. There is also some hotspots around Birmingham. And then, of course, there's a lot of air pollution around Los Angeles and San Fresno Valley, where it is said that good air goes to die. So there is all this air pollution that is located in few areas. And as you can see from the overlapping mortality map, that there is excessive mortality associated with areas where there are high levels of air pollution. So there is an association, at least geographic association, between high levels of air pollution and premature cardiovascular mortality. But if so many people are dying from air pollution, the question was that what are the underlying reasons? Why are these people dying? So if you look at cause-specific mortality, you can see here that most of the deaths occurring due to or associated with PM exposure are due to cardiovascular diseases, including diabetes, as you believe, cardiovascular, diseases as well, and ischemic heart disease. And so these dots represent the number of people who are number of premature deaths. So if you put all of them together, you can see that a major burden of air pollution is in terms of cardiovascular mortality. So why is it that the cardiovascular tissues are particularly sensitive to exposure to air pollution? You would think that because air pollution is inhaled, that the major toxicity would be pulmonary, but somehow the lungs seem to be more resilient to inhaled toxins than the heart. As Anna sort of talked about lead and arsenic, and Bruce is talking about lead also. So whether it's inhaled or ingested, I think the cardiovascular tissues seem to be particularly vulnerable. So to see this sort of vulnerability, we did a study, and this was several years ago. This is Provo, Utah. And in Provo, which is in a valley, there are times in the year where you get a very pronounced inversion, and this inversion leads to an increase in the concentration of PM from, say, like 5 all the way to like 100, and then this could then oscillate. So what we did is we recruited individuals before, during, and after this inversion, or this episode of inversion, and looked at circulating blood cells that are essential or required for repairing blood vessels, and we call them progenitor cells or endothelial progenitor cells. And as you can see that with the increase in air pollution, there was a decline in the number of these cells. So it would seem that exposure to air pollution, rather than just causing premature mortality, would inflict some sort of a subclinical injury that could then manifest into a full-blown clinical disease. But to actually go back and establish a relationship between exposure and injury, we developed an animal model in which we collect air from downtown Louisville and then concentrate PM and expose mice either to this concentrated PM or to filtered air. And then looked at their blood cells. And we found something very similar to what we found with the cohort in Utah, which was that when these mice were exposed to air pollution, there was a decrease in the number of these circulating cells, again suggesting some sort of subclinical injury that might be linked to the development of cardiovascular disease. So in order to then look at what could be the mechanism, we examined a whole panel of cytokines in the blood and trying to see if there was some particular sort of biomarkers of inflammation that might be associated with the with cardiovascular injury. So interestingly, what we found that most of the cytokines that were actually increased were anti-angiogenic, and most of the angiogenic cytokines like VEGF and PDGF and EGF are all suppressed. So what it seemed to us from this data was that maybe there are some effects of air pollution that are sort of mediated by a suppression of the angiogenic response and a sort of increase in the anti-angiogenic response. So which means that people who are exposed to high levels of air pollution are are less capable of repairing blood vessels and to generate new blood vessels instead of response to injury. So in order to actually document this injury, we looked at something that are known as the endothelial microparticles, and these are circulating microparticles that actually are sort of cleave off or pinch off from the endothelium, which is the lining of the blood vessels, and circulate in the blood. And so we collected the level of these microparticles, again, from a cohort in Utah. This was a sort of subsequent follow-up study before, during, and after inversions. And as you can see, that as an increase in the PM concentration, there was a parallel or a sort of a straight line increase, a linear increase in the number of microparticles circulating in the blood. Again, sort of getting to the point that exposure to PM can induce some sort of subclinical vascular injury that, if sustained and persistent, could ultimately lead to chronic heart disease. Alternatively, in susceptible populations who already have pre-existing cardiovascular disease, this sort of subclinical injury could precipitate a cardiovascular event. But it's not just the effect on heart disease and vascular injury, but also in some data exists showing that there may be an association between exposure to air pollution and diabetes. And as I said, that we consider diabetes a form of heart disease because it is, in our view, it originates primarily from blood vessels, but also that most diabetics, I would say about 70%, would eventually actually die not from diabetes, but from heart disease. So you could see that the areas where there are high levels of diabetes are the same areas where there is high levels of PM 2.5. So again, although this is a provocative sort of indication that there might be an association between diabetes and PM, it doesn't constitute sort of causative data. So we went back to the lab again, and this time we're looking at mice. And in these mice, we exposed them to concentrated air particles. We call them caps, or you can expose them to air. And as you can see, that after long-term exposure, these mice that were exposed to caps had much more dysfunction in glucose regulation, or much more difficulty in maintaining glucose homeostasis than the mice that were exposed to filter air. Again, suggesting that exposure to air pollution could have direct effects on inducing insulin resistance, and perhaps both insulin resistance and the associated sequelae of diabetes and obesity also could be in part linked with exposure to PM. So what we think may be happening is a rather complex set of events that start with the exposure to air pollution, changes in the lung, particularly the subclinical low-grade inflammation, leading to more systemic inflammation that increases the risk of a variety of different cardiovascular disease risk factors, and that may be because of the underlying sort of mechanistic similarity, or you can call it common soil, over which both insulin resistance, diabetes, as well as heart disease develop. And then that could be leading to some clinical manifestations. So this sort of a direct understanding of a detailed link between air pollution and heart disease, as well as trying to link them mechanistically, would then suggest that there may be a positive link. So it strengthens our rationale for actually not only developing sound policy to be able to regulate the exposure to air pollution, but then also would provide us some indication of the particular aspects of air pollution that might be clinically more evident than others, so that we could not only recognize the effects of air pollution in a clinical situation, but also sort of develop evidence-based policies to guide clinical practice as well. And so it was in, I think about 5 years ago or so, that the American Heart Association came out with a scientific statement suggesting that air pollution exposure is causally linked to heart disease, and therefore it may be an important consideration both in preventive care as well as in clinical medicine. So I would end there and hand over the slides back to Ted.
Thank you very much, Aruni. A wonderful presentation. To our participants, I said, please use the chat box to enter your questions, but actually there's a Q&A box, so my mistake, but there it is. So if you have questions you'd like to present to any of the speakers, use the Q&A box and we'll get to them. Let me just start the discussion by picking up where you just left off, Aruni, and mentioning that the American Heart Association has adopted a policy on particulate air pollution, which raises the question about the extent to which the material that any of the three of you have presented is actually making its way into clinical practice of medicine, not only in the care of individual patients, but also in terms of clinicians actually becoming advocates for more protective public policy. Do any of you have just sort of brief reflections on that issue and where some progress has been made, and on the other hand, where we might be able to do more?
So let me begin. I would say that there are two issues here. One is in terms of policy. Yes, I think we've made a lot of noise and provided as rigorous evidence as we could to convince lawmakers that air pollution exposure is indeed a significant factor to consider. So that's one front we're fighting on and trying to lower emissions. But that's one thing. The other issue is in the clinic now, knowing that somebody's exposed to air pollution and that could be contributing to the disease doesn't directly provide our physicians any actionable information. So, but we're trying to develop guidelines in which we can say, for example, if people have high cardiovascular disease risk, they could avoid pollution to air pollution, exposure to air pollution by not going out in the days of sort of high air pollution. We can also advise that people with high risk, particularly those with heart failure, may avoid living near areas with lots of traffic, and of course, minimizing exposure to things like tobacco smoke and secondhand smoke indoors.
Thank you.
Yeah, I totally agree. I think from the clinical perspective, there are things that clinicians could do, and such as at least understanding where do their patients live. If somebody has had an MI, where are they going back? Are they going back to live near this house that is maybe near a highway? And maybe there are some ventilation measures that could be recommended, some preventive measures that could be done. I mentioned this chelation trial that is trying to understand if chelation could be useful as a tool to remove this excess burden of metals within the body. And the original, one of the trials, the first trial showed substantial impact and benefit, but the metals were not measured in that trial. So there are still many questions open. And hopefully this second trial, this TAC2 trial, can provide additional recommendations. Then the other thing I would mention is that from the clinical perspective, the number of clinical guidelines that recognize air pollution or metals as risk factors for cardiovascular disease is relatively small. If you go and look at those guidelines, there is 1 or 2 for air pollution from the AHA, but not much more. So I think for clinicians to recognize that cardiovascular disease is more than just the traditional risk factors, lipids, diabetes, smoking is the most environmental thing that clinicians are kind of aware. So I think there is a lot of noise that you can still make to move beyond this policy noise that we've been, I think, good at making, although much more needs to be done, to move more into the clinical world. So hopefully we can continue, and I think hopefully activities like this one today can help.
Thank you. Bruce, do you have anything to add?
Well, just 2 thoughts. One is, I imagine many of the people watching today, and probably all of us presenting, are asking the question, how much of it is air pollution and lead and arsenic separately, and how much of it is the combined impact? And of course, we don't have as much data there, but what I think we could all agree, I think we all would agree, that many of these have been underestimated in terms of their overall impact, and certainly in terms of the decline. One of the things that I think is especially fascinating about this area is that when we start to look at the impact of high risk versus low risk, this is the work that Jeffrey Rose did, and his work was so focused on cardiovascular disease. And what it basically reminds us is, if we want to prevent death, disease, and disability, we really have to look at the population strategies, reducing exposure across the entire population. And so as much as all of these points about bringing it into clinical perspective are extraordinarily valuable, it's also extremely important to think about the low-level exposures, the population impacts.
Thank you. And for those participants who aren't familiar with it, I refer you to Bruce's really wonderful videos that I mentioned at the outset, where he describes in very simple but understandable terms precisely what he just said about the population-wide impacts of small changes. We have a few questions on the Q&A chat box. One question is, does drought affect arsenic levels in drinking water and food grown with that water supply?
Yes, that's a great question. Generally, the levels of arsenic in a well that is open and has been drilled for many years, they generally don't change much. They tend to be quite constant. However, in the way that really drought affects arsenic exposure to the population is because more and more communities are drilling new wells and are trying to find new sources of water and places that are arid and do not have much access to water, and groundwater is a major source. So in that manner, it has a major impact. And I saw that there is this other question on arsenic. Should I answer it now that I am at it?
Yes, please go ahead.
So, yeah, regarding the question about what is the importance of the levels above 15.7 microgram per gram of creatinine, and see if these levels are problematic for cardiovascular disease and how clinicians can utilize this information. Yes, these levels are of concern. The evidence shows, I would say, above 10 micrograms per liter, there is an excess risk. So that's important information. And I think what clinicians can do is to ask their patients, are you actually using a private well? Private well users in the US are not protected right now. From a policy perspective, something needs to be done because these are millions of people currently, these are millions of children being born in places without being protected. So just because they are using a private well. So some states have developed policy to protect those private well users. I believe it's just 2 or 3 states that have some minimum policy. So more policy is needed and more clinical awareness of this issue for interventions and asking your patients and knowing what your patients are drinking in terms of water and what are they eating in terms of rice can be useful.
Thank you. There's an earlier question about research showing, wondering whether there's any research showing that if someone with cardiovascular disease who reduces air pollution or heavy metal exposures actually improves their health. You briefly touched on that with regard to air pollution. Do you have additional thoughts with regard to studies that demonstrate the efficacy of reduced exposures either to the metals or to air pollution? If any of you have thoughts on that.
Well, yes, I can add a few things. So first is, like Bruce was saying, these effects are more evident on a population level than on individual level. So we do know from studies around the US cities that in areas where they have decreased the levels of air pollution, I'm talking about cities like Pittsburgh and Philadelphia and New York, that you've actually seen an increase in life expectancy. It varies from 4 to 6 months, but it's a significant increase. So it shows that avoiding air pollution could sort of decrease the risk of heart disease. So therefore it's, but on an individual level, it's a little bit trickier. I know that a couple of trials are going on in which they are looking at the effect of masks and filters and nose filters that when used would decrease the risk associated with exposure to air pollution. So those are the only other things that I'm aware of. And I may have something to say about the heavy metal part. I don't know whether there's some evidence there.
With the arsenic, there is evidence that when you remove arsenic from the water, there is a reduction in the trends of cardiovascular disease. There is evidence from Chile around this. Those levels were very high. So whether that impact is going to translate at the lower levels, that there are no studies done. However, arsenic exposure in community water, drinking water system users has declined 17% in the US population. This is a study that we published a few years ago. So what is the impact of that reduction? Could it also have an impact like Bruce showed for lead? We don't know that. So I think that research is important to keep motivating policy and for us to really be able to have a good assessment of what's happening and not missing the importance of these risk factors. So that there is some evidence, but I think we need more.
Thank you. And I can't help but note, Aruni, you mentioned the improvements in life expectancy in Pittsburgh with the reduction in air pollution, and they're just about to start building a cracking plant there to make plastics out of all the fracked gas that's coming out of that region. And the prospect is that the air pollution gains are going to be reversed. So this is an opportunity maybe for clinical practitioners to weigh in on the implications of this for their health. There's another question here about some regions of North America have high levels of cadmium in soils and that this is hyperaccumulated in grains. Is research proceeding on exposure to cadmium in food and links to health outcomes?
So I can maybe answer something about this. We didn't have time to cover cadmium today, but this is kind of, I would say, the other third metal that has very substantial evidence on a role in cardiovascular disease. And it's very interesting what you are talking about. For instance, in the North and South Dakota, I believe also Minnesota, all those areas are very high in cadmium in the soil. And we know that that food can accumulate cadmium, as it was mentioned. In the Strong Heart study, our participants in those areas had higher cadmium levels, even if they didn't smoke. So the question is it related to the soil? And is it coming through the food? We tried to do some food assessment, and we could find some evidence on a food connection. But the food questionnaires are always so challenging. And regarding the issue with the glyphosate, I think that's very interesting also to have a better data on this. This is kind of a growing interest among many of us to understand how these chemicals kind of interact with each other and influence each other. So definitively a lot of interest on doing this together. And I am going to also refer to what Bruce mentioned earlier of understanding these chemicals in a combined, cumulative, mixture way, and not just individually. That is what we've done so far. So I think that those are important research questions.
Yeah, thank you. And I would add that is terribly important because, as Bruce and Aruni pointed out, there was this really interesting coherence about when blood lead levels started to fall and when air pollution improvements began as well. And there have been dramatic improvements in the United States. Lead levels have dropped. Air pollution has dropped dramatically in many, many areas. And you've pointed out the benefits to cardiovascular risk. And I would also add that a number of studies, some of which have been done in the United States, are showing that the age-specific incidence of dementia is falling, and it's not explainable by improvements in behavioral factors like better smoking, better diets, better exercise. And I would suggest that it's quite likely, in fact, that the drop in lead levels and the improvements in air quality have been contributing to that. It's about 40 years now, sort of an unintended or perhaps unexpected consequence of good public policy. We've come to the end of the hour. I really want to thank our speakers for wonderful presentations and discussion. I think it's been very, very useful. And for our participants, the recording and the slides and all will be in the archives for you to refer to again. So thanks again to our speakers, and Maria, I'll turn it back to you.
Great, thank you very much, Ted. We are approaching the end of today's webinar. A video recording will be available on the CHE website soon, and tomorrow you will receive an email containing a link to the video. CHE's next webinar will take place Monday, October 1st, and is titled Wildfire Smoke, Impacts on Public Health and Lived Experience. To learn more into RSVP, please visit our website at healthandenvironment.org. If you are new to CHE and would like to stay updated about upcoming events and more, please sign up to receive our newsletter by selecting the Join Us tab at the top of any page on our website. Additionally, if you appreciate these CHE partnership webinars bringing you the latest environmental health research for free, we encourage you to support CHE's ongoing work by making a tax-deductible donation via our secure website. Again, our website is healthandenvironment.org. With that, I would like to thank our speakers once more for taking the time to present today, and Ted for his excellent moderation. Thank you so much for joining us, and have a great day.